Okay, so last week we established the aggressive factors. Was it aggressive factors or protective factors? I don't know which one we did, but I think it was aggressive factors. And we said that these aggressive factors can also be referred to as the causative factors of hyperacidity, which manifest as peptic ulcer disease or gastroesophageal reflux disease. So I don't know, before we start, I don't know if anyone has questions based on what we said last week. I'm going to make a quick recap for like 5 minutes or so. So, what are some of the aggressive factors that we mentioned last week? Yes, good evening.
You said H. pylori testing dehydrated acid in the stomach.
Okay, H. pylori hydrochloric acid in the stomach. All right, good. Thank you very much. So, like I told you last week, that the main causes of peptic ulcer disease would be Helicobacter pylori. I think I said that. And I also said that misuse of non-steroidal anti-inflammatory drugs, that's a class of analgesic that people commonly misuse. Okay. Now the reason why I'm using misuse is because misuse is a broader term rather, and it's better than just saying abuse, because abuse can sometimes have this connotation that it's a psychoactive drug. So sometimes to be more accurate, we say misuse. So people can commonly misuse NSAIDs, and NSAIDs can cause peptic ulcer disease. So what is the mechanism? What did I tell you about the mechanism of NSAIDs and peptic ulcer disease? Yes, go ahead, please. I'm listening.
So it reduces the prostaglandin production, which protects the stomach.
Excellent, very good. So NSAIDs reduce prostaglandin, and I told you that prostaglandin has this housekeeping function, and the housekeeping function is that it protects the stomach. Now, it protects the stomach because prostaglandin can stimulate the mucous cell to produce mucus and bicarbonate ion, and bicarbonate ion can help to neutralize the stomach lumen. Okay. Now, in fact, I told you that there's a difference between the pH of the lumen and the pH of the stomach epithelium or lining. Okay, so the mucous cells are responsible for the production of mucus and bicarbonate ion, which can help to protect, the lining of the stomach. Okay, so prostaglandin is very important in stimulating the mucous cells to produce mucus and bicarbonate ion, which are important protective factor. And another thing prostaglandin does is that it enhances the flow of blood in the GIT, and blood flow is also very important for the normal function of the stomach. So that's why prostaglandin is important. So if you take NSAIDs, which inhibit prostaglandin synthase, referred to as cyclooxygenase, then it can trigger ulcer. All right, we compromise the lining of the stomach, and as a result, acid produced can now attack the lining of the stomach. So we said a lot of things about the aggressive factors, and I told you some of the important cells of the GIT and what they produce. Now we talked about the cephalic phase of acid production that involves the activation of the vagus nerve. Now, and when the vagus nerve is activated, it releases acetylcholine. Now, this acetylcholine goes to the G cells to stimulate the production of gastrin. All right, and gastrin binds to cholecystokinin receptor on the parietal cell to stimulate the production of gastric acid. All right, then we talked about G cells that produce gastrin. Then we talked about the production of histamine too by the enterochromaffin-like cells. All right. Now, acetylcholine released by the vagus nerve can also stimulate the enterochromaffin-like cells to produce histamine. All right. Now, and histamine will bind to the histamine 2 receptors on the parietal cell to also stimulate the production of hydrochloric acid by the parietal cell. So the parietal cell produces hydrochloric acid. And we said it also produces one other thing. Who can remember? Parietal cell produces hydrochloric acid and one other thing. Anybody that can remember?
Intrinsic factors.
Intrinsic factor. You will marry a woman. Intrinsic factor. Thank you very much. Yeah. So intrinsic factor. And this intrinsic factor, we said, is vital, is important for vitamin B12 absorption. Okay, so very good. Now it's important you know this physiology. This is the only physiological aspect of the gastrointestinal tract I want you to know. So you must know the way. You know, one thing about me is that I don't ask students questions I cannot store in my memory. So the first thing I do is that when they give me a topic, I try to read the topic and see whatever can pass through my brain. I believe whatever can pass through my brain can pass through your brain too, because you guys are more intelligent than us. So uh my yardstick for what I am going to give you is whatever can pass through my brain, because you guys are smarter. So if it can pass through my brain, then it can pass through your brain 100 times. Okay, so that's the way I teach. I first memorize whatever I want to teach, and if it is not sitting in my brain, then I cannot ask you the question. So because I have taken my time to learn this, I believe you guys too can also learn it. Okay, so now the enterochromaffin-like cell produces histamine. Histamine binds to histamine 2 receptor on the parietal cells and inhibits the production of acid by the parietal cells. So that's why we use histamine 2 receptor antagonists to treat peptic ulcer disease. Histamine 2 receptor antagonists like cimetidine, famotidine, ranitidine, we will talk about them. Then which other cell did we talk about that also can stimulate? Yes, we also talked about pepsin or pepsinogen. Pepsin is also one of the aggressive factors, and pepsinogen is first produced by the chief cells. All right, now, and these chief cells produce pepsinogen. Pepsinogen is a precursor to pepsin. Then the hydrochloric acid that is produced by the parietal cell helps to, I don't know the reaction, it might be hydrolysis, maybe hydrolyze the pepsinogen, and pepsinogen is converted into pepsin. And I told you pepsin is important for protein digestion, because protein digestion starts in the stomach. So you need pepsin for this protein digestion. And like you know, our skin, protein, every part of our body, protein, your epithelium, protein. So if pepsin can recognize your protein in your food, it can also recognize the epithelial lining of your stomach, and it can digest it. So pepsin is also an aggressive factor when it comes to peptic ulcer disease. Okay, now so pepsin is not a chief cell produces pepsinogen, hydrochloric acid converts pepsinogen into pepsin, and pepsin is an aggressive factor. Another aggressive factor we talked about is bile acid, and we said bile is very important, particularly for the emulsification of fats, digestion of fats in the body. Bile is very important. Okay, so now when the pyloric sphincter, where is the location of the pyloric sphincter? We talked about the pyloric sphincter the last time too. So what is the, waiting I ask you now? I've forgotten what I just asked. Okay, the location of the pyloric sphincter.
So
Yes.
it should be located above the small intestine, between the
Yes.
stomach and the small
Yeah,
intestine.
between the stomach and the small intestine. Because where bile is needed in the duodenum. All right. So and that is where it is released into. Now, so if there's a reflux of bile acid from the duodenum into the stomach, it is also an aggressive factor that can trigger now peptic ulcer disease. Okay, now so having said this, let's move to the protective factor. You already know the protective factor, and typical examples of the protective factor include the mucus that is produced by the mucous cell and the bicarbonate ion that is produced by the mucous cell. Of course, you know bicarbonate is a base, so it can help to neutralize the acid content of the GIT. So these two are being produced by the mucous cells, which is bringing us to another cell. Then I also told you about D cells, the D cells that produce somatostatin. And somatostatin serve as a negative feedback for the G cells to stop the production of gastrin. Now, you guys know about homeostasis, all right? Everything in the body has a balance. We fall sick when there is an imbalance. When the production of acid is going up, a signal is sent to the D cells to produce somatostatin to bring down the production of gastrin. And when gastrin production is reduced, the production of hydrochloric acid also goes down. Okay, so somatostatin produced by the D cells serve as a negative feedback to the G cells when there is hyperacidity in the stomach. Okay, so the stomach can now reduce the production of hydrochloric acid. So I hope you guys are following me. Now, and another important protective factor is the prostaglandin. Now, in fact, that's why you will see, who knows this brand, Atrotech. So Who has come across that brand, Atrotech? Anybody? Atrotech.
Yes,
Yes.
sir.
So what's the what does it contain? What are the
Diclofenac and misoprostol.
diclofenac and misoprostol? What do you think? Why do you think there is that combination? What's the essence of that combination?
Misoprostol protects the stomach lining.
Okay, very good. Now, so misoprostol is a prostaglandin analog. Misoprostol is just like a prostaglandin. And you know, I told you that prostaglandin is a protective factor in the GIT. So misoprostol is a prostaglandin analog. All right. Although it's an abortifacient, we usually don't recommend anything to a girl in her reproductive age. Now, you see, one of the things you must note, see, anytime you are attending to any patient who is in a reproductive age, you must always rule out pregnancy. Don't assume. Even if the person comes to you dressed in scarf, flowing skirt, flowing gown, when you're attending to a lady in a reproductive age, the first thing you want to rule out is pregnancy. I'm telling you this from experience because sometimes you now give drug to that person. The person now comes back a week later and tell you she's bleeding because you have terminated the person's pregnancy. Always rule out pregnancy. So for Atrotech, Atrotech contains diclofenac, which can directly irritate your GIT. Like I told you the last class, diclofenac can directly irritate the GIT. Then it also inhibits prostaglandin. All right, it inhibits prostaglandin. So your patient has pain. Then you're also careful. You don't want that patient to come down with peptic ulcer disease, so you want to give that combination. But misoprostol is a prostaglandin analog, and it is also an abortifacient. So you want to be sure that your patient is not pregnant, or you don't even want to give to a female patient. Just don't give. You can give to male patients to go and use. Okay. Then some female patients we deliberately come for Arthrotech, knowing that if they come for misoprostol, you may not want to sell to them because it's an abortifacient. So they will disguise and come for Arthrotech and ask you that they need Arthrotech. And Arthrotech has misoprostol, which can trigger an abortion. Okay, so that's why you have that combination, because misoprostol, of course, is an is a prostaglandin analog, and prostaglandin is needed for blood flow in the GIT, to also stimulate the mucous cell to produce bicarbonate ion and mucus. So these are some of the protective factors. I don't know if there's anyone, I don't know if there's any protective factor I've skipped. Okay, so if you the some of the prostaglandins include prostaglandin F2, prostaglandin I2, and all. Okay, so please take note of, I think we are done with this. I'll project antacid now. So take note of some of these receptors that these guys bind to. My device is echoing. Um, the acetylcholine by the vagus nerve binds to muscarinic 3 receptors. Gastrin binds to cholecystokinin receptor. Uh, what else? What else? Histamine binds to histamine 2 receptor. Okay, so note some of these receptors. And we can use anti-muscarinics, anticholinergics for peptic ulcer, particularly pirenzepine, propantheline. They are muscarinic blockers that you can use for peptic ulcer disease, but we usually don't use them. That's why you see that people don't use anticholinergics for peptic ulcer disease, because there are adverse effects like dry mouth, blood vision, and all of that. So, and it is not as effective as you directly inhibiting the proton pump itself. So we usually don't, they are not commonly used. All right, but it's just good to mention this here. Now then, in time past, they used to do vagotomy. Vagotomy is the surgical removal of the vagus nerve. But you see, the vagus nerve is also very important for periostasis. You have a question? Anybody has a question? You guys can hear me, right?
Yes, sir.
Okay, so like I was saying, in time past, they used to, before proton pump inhibitors, before histamine receptor blockers, medical doctors used to, surgeons, they open the stomach, cut the vagus nerve, and when they cut the vagus nerve, Of course, the hyperacidity will stop. Now, but the disadvantage is that the vagus nerve is also very important for periostasis. So if you do vagotomy in a patient, some of them may now find it difficult to for their gastric content to move. Okay, so when you eat, the food may still be in your stomach for long because they have removed your vagus nerve. So nobody does vagotomy again. Thank God to pharmaceutical science. Thank God to knowledge of drug discovery. All right, so that's that about the aggressive factor and the protective factor. And also we have talked about the causes of peptic ulcer disease. Then we talked about the lifestyle factors too, like smoking, alcohol. These are very important factors that may trigger or aggravate peptic ulcer disease. And also, let's now face the treatment. What are the treatments? Now, the parietal cells produce hydrochloric acid via the proton pump. We call it proton pump. It is hydrogen. I think I should write it. Now, the proton pump is H plus potassium plus ATPase. Okay, so this is the proton pump, and from the name, what it does is that it takes in potassium ion into the cell and releases hydrogen ion into the lumen of the GIT. So that is what it does. Now, this proton pump can directly be inhibited. Okay, so that's why we have proton pump inhibitors. The proton pump can directly be inhibited. Another target is the histamine receptor. There are so many receptors on your parietal cells, the parietal cells that produce acid. There are so many receptors there. You have the proton pump itself, which release the acid. Then we have histamine 2 receptor, okay, which histamine produced by the enterochromaffin-like cell bind to. All right. Then we have the which other receptor? Cholecystokinin receptor, which gastrin bind to. Okay. Now, so out of all of these, we have proton pump inhibitor. Then we have histamine 2 receptor antagonist. And we have PCAB. All right. This PCAB targets the potassium part of proton pump. That is where it targets. It targets the potassium part of proton pump because, of course, the proton pump has two parts: the hydrogen potassium ion ATPase. Okay, so the PCAB target directly the potassium part of the proton pump. So let's go into lecture proper now. But we have the antacids. The antacids are used for symptomatic relief. So that's where we are going to be starting from. Now, if you want to cure peptic ulcer disease, you use proton pump, not antacids to cure. Antacids are just for symptomatic relief. And I think that's where we are going to be starting from today. Antacids cannot cure your peptic ulcer disease. They can only relieve the symptoms. All right. So let's say some things about antacids. Antacids are usually weak bases, and what they do is that they neutralize the stomach acid. Now, the interesting part is that you cannot use strong bases. You can only use weak bases. And the reason is because we are not doing allopathy. It is in allopathy that you say you use madness to cure madness. I don't know if you have heard of allopathy before, maybe in pharmacognosy. Yeah, in allopathy, they say we're laughing, we're. That's how they say it in Yoruba. You use madness to cure madness. But in peptic ulcer disease, you cannot do that because a strong acid is being produced in your stomach. You can also use a strong base to neutralize it because a strong base is caustic. If you drink it, it will cause more harm than good to your GIT and your software to your GIT. So we use weak bases. So don't forget, antacids are not just bases, they are weak bases. And what they do is to neutralize stomach acid to produce salt and water, like you already know. And some of them can also have protective functions on the gastric mucosa. Now, antacids are generally hydroxide and carbonate salts or carbonate bases of group 1, group 2, and group 3 metals. Now, group 1, they are also called what? On the periodic table. I know you guys like chemistry a lot. You are all Dr. Toby's children. Group 1 on the periodic table, they are called what? Okay.
Alkali metals.
Alkaline metals. Thank you very much. Thank you. Alkaline metals. Yeah. Thank you very much. So there are hydroxides and carbonates of group 1, group 2, and group 3. All right. Now, so in that way, although there's another metal, bismuth. I can't remember the group that bismuth belongs to, but I think bismuth is a transition metal, if I'm right. So So we have aluminum, we have calcium, we have magnesium, we have sodium, potassium, bismuth. Now, all salts of group 1 are soluble, I think, if I still remember chemistry very well. But I'm not a fan of chemistry. But I think all salts of group 1 are soluble. That's if I still remember. So antacids can now be broadly classified into absorbable antacids and non-absorbable. There are antacids that once you drink them, they will be absorbed in your stomach. And there are some that they will not be absorbed. They just neutralize and they pass out through feces. They pass out from your body through feces. And that's why sometimes, in fact, what type of reaction do you think antacids have? Like, how do they act? Will you call them systemic drugs? But are they
Local action.
local action? Actually, that's what I should have said. Local action. Thank you. So what they do is the action is local. You drink them, and right in the lumen of the GIT, they cause neutralization, and the action is local. They produce salt and water. Now, the absorbable ones, sodium bicarbonate, baking soda, your common baking soda, is an antacid. Okay. Now, and sodium bicarbonate is also soluble. So once you drink it, it neutralizes, then the salt that is formed will be absorbed in the GIT. Okay. Now, the disadvantage of this is that we don't want, there are some people who are on sodium diet restriction. So if you ask them to go and be drinking sodium bicarbonate, then it becomes a problem because you are going to raise the sodium level of the body system, and you don't want to do that. So sodium bicarbonate is really, really not used in peptic ulcer disease, although it's a fantastic antacid, and I think it's the most rapid when it comes to action, because it's once you drink it, it's in solution form, not suspension like the other ones. All right. So sodium bicarbonate, your baking soda, is an antacid. We have magnesium oxide, magnesium carbonate. Then we have the ones that are non-absorbable, like your aluminum hydroxide, magnesium silicate, magnesium hydroxide. Now, most of the antacids you have in the market contain aluminum hydroxide and magnesium hydroxide, most of your antacids. Now, while we have magnesium silicate alone, so in the hospital, you can see something like MMT. MMT is mixed magnesium silicate or trisilicate, okay? And people also often refer to it as mixed mag. Now, so when they say I need mixed mag, they are referring to mixed magnesium trisilicate or magnesium trisilicate alone without aluminum. All right. So don't make that mistake. If you see a prescription that says mixed mag, don't give them give me all the names of those antacids. I know they practice again. All those common brand names.
Jesse, Jeffro,
Okay, thank you. Jested.
Gaviscon.
Gaviscon. Okay, thank you. Now, so when somebody says I need
Jekro.
mixed Jacro, yes. When somebody says I need mixed mag, mixed mag is just magnesium alone. It doesn't have aluminum. Okay. I think Jacro is also a type of mixed mag. I think it contains only magnesium. I'm not too sure, but I think so. It contains only magnesium. So mixed mag is just magnesium alone, magnesium trisilicate. Now, and there is a reason why. All right. Now, because aluminum salt cause constipation, while magnesium salt has laxative effect, cause diarrhea. Okay. Now, sometimes in the hospital, the physician may prescribe magnesium trisilicate just for the laxative effect. Okay. A patient may have indigestion, or probably there's a post-operative patient and they want bowel movement, or the patient is on tramadol, opioid analgesic. Have you done opioids? Have you done opioids? You have not really done much. So I withdraw my statement. You people are not pharmacists already. I have not done much. Okay, so opioid analgesic. Yeah. Since you people didn't unmute to tell me, I already know that you have not done it. It's easy to I understand your class so well. When the responses are not forthcoming, it shows that teach you know. So I know. But it is well. It is well. It is well. All right. So the opioid analgesic will cause constipation. Okay. Now, and I'm telling you this. See, if you understand pharmaceutical science very well, anywhere you go to, they will feel you, as in the normal feel. They feel this person's vibes. But if you don't understand pharmaceutical science, You need to do more than cram and pour if you want to, that kind of ego you will have when you have dropped stuffs. That I've dropped stuffs. Okay, let me give you an example. A relative of mine had a prostate surgery. He had a benign prostatic hyperplasia. Okay, so he had a surgery, and I went to visit the patient in the hospital. It's Lautech Teaching Hospital. So, post surgery, he was placed on tramadol, which is an opioid analgesic. Now, the essence of the tramadol is to reduce pain, of course, post surgical pain or post whatever pain. So, for like 1 week or thereabout, he has been complaining that he's constipated. So, the day we now went there, he started vomiting. Of course, because he had not had bowel movement, he would vomit. So, and while I was there, I had gone through his drug tray. So I knew the things they were giving to him. So the nurses were like, kilo tu shele, ten throw up. Not all of you understand Yoruba. That waiting they happen, why are you throwing up? And all that. So he now said he has also not been stooling, that he doesn't know what is wrong. And they were like, oh, maybe they should get him orange so that he should eat the orange, not just squeeze out the juice, eat the orange with the fiber and all of that. And maybe they will give him something for vomiting. So I just told the nurse, I said, come on, sorry. I know I'm nothing in your hospital, but I think your patient is on opioid analgesic and it's normal for him to be constipated. If you stop that opioid analgesic, then your orange prescription is going to work. But if you don't stop it, if you like, it make you eat all the orange way there for Nigeria, it will still not pass through. The nurse was looking at me. Now went to call the medical officer in charge that this person said this. And they effected that thing immediately. So the doctor was not like, who are you? Who you be? You know that kind of thing. When somebody give you anything, you will just say, identify yourself. Who you be, who you rep. So I can't tell him, say, oh, I'm a pharmacist and all. So, and eventually, my relative started stooling. Because of that, my relative now overrated me. So every other thing they give him in the hospital, he will now come and say, I don't know that one. I was just fortunate to remember that tramadol constipates, and that's why any other thing the patient could just call me. They said they want to remove catheter. I said, I don't know. Where's my own with catheter? You understand? So, but sometimes you can just show yourself and make interventions, and people will respect you for that. So, aluminium constipates while magnesium cause diarrhea. This one I'm going to ask you in MCQ. Just for this one I'm going to ask you. Aluminium constipate, magnesium cause diarrhea. I am going to ask you. Okay. The way I know it is that the way I crammed it is I said ACMD, 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 ACMD. So AC is aluminium constipate, MD is magnesium causes diarrhea. In fact, that's where I memorized it from pharmacy school days. ACMD, aluminium constipate, magnesium causes diarrhea. So that's why you will see that they now combine aluminium and magnesium in the same antacid. So one constipate, the other causes diarrhea, then the effect cancels out. So you will have a little or no effect on your bowels, okay? Because the effect we cancel out, they have is more like counterproductive. Aluminium constipate, magnesium causes diarrhea, then the effect cancels out. We're almost wrapping up. I think we have 13 minutes left. So if you pick an average antacid that is not a mixed mag, you will find aluminium, magnesium. There may be some other components for some reasons, which I am still going to explain to you. So don't forget, aluminium constipate, magnesium causes diarrhea. If you need a patient to take something that can make the person that has a laxative effect, you can recommend mixed mag. In fact, how many of you know Andrew's liver salt? How many of you know Andrew's liver salt?
Yes, sir.
Yes, Andrew's liver salt contains magnesium salt. So, and that's why some people use it for relief, for comfort, when they feel they are constipated or they've not been going to the toilet. If the toilet habit changes, okay, so they use it to just to get some relief from constipation. So the Andrew's liver salt also contains strictly magnesium salt, okay, because magnesium has this osmotic laxative effect. So, but basically, antacids are not used for curative, they are used for symptomatic relief. So you can use them for, like we said, gastric esophageal reflux disease. Now, but the antacid you are going to use for gastric esophageal reflux disease must contain alginic acid. Okay. I'm saying this, it's still in the notes, but I have to say this before I forget. I have to link it to gastric esophageal reflux disease. Now, the antacid you are going to use must contain alginic acid. If it doesn't, then it is not all totally useful for gastric esophageal reflux disease. So if your intention is gastric esophageal reflux disease, you must use an antacid that contains alginic acid, and that is one of the major components of Gaviscon. Okay, and that's why Gaviscon is marketed for gastroesophageal reflux disease, because it contains high content of alginic acid. Now, so what does alginic acid do? Let me explain to you using a diagram. If this is your GIT, okay, I'm not very good at drawing. I pardon me, please. That's why I don't like anatomy. Okay, let's say this is your GIT. If I know you guys very well, I would have mentioned someone's name. Let's say this is this person's GIT. Okay, so when you take alginic acid and it comes in contact, in contact with your stomach, what happens is that it now forms a raft, like a cloud. It forms a raft. We call it raft. That's for alginic acid. Okay, it forms a raft in your stomach. All right, it forms this raft. Okay, and you know where it is forming this raft? Yes, last week I told you that this is where the lower esophageal pylori lower esophageal sphincter is located. So what happens is that when you drink an antacid that contains alginic acid, as it's getting into your stomach, there's a reaction, then it goes up and form a cloud just at the lower part of your esophagus. Now that raft that alginic acid is forming will now prevent the backflow of the gastric content. Okay, so and that's why alginic acid, if you want really to target gastroesophageal reflux disease, you need to take an antacid that has alginic acid, which can help to form a covering, a raft for your esophagus to prevent the reflux of your gastric content. Do you understand, or should I explain this again? You understand, right?
No, sir.
No or yes?
No.
Okay, so let me go over it again. Now, alginic acid is one of the components of Gaviscon. Look at this image. What is here? Sodium alginate, right?
Yes, sir.
Okay, it's tiny anyway, but the sodium alginate is here. Sodium alginate, 250 milligram. In fact, it's the most important thing there. Sodium alginate, 250 milligram, high strength alginate. So this is, you will see that the first thing they wrote here is heartburn. So it's specifically for gastroesophageal reflux disease. So like I said, what happens is that when you take anything that has alginate and you drink, when alginate gets to your stomach, there's a reaction. And that reaction makes it form something like a cloud over just at the lower end of your esophagus. Okay, it's more like the covering that the lower esophageal sphincter should give to your esophagus. The alginic acid is going to give it that covering. So it forms a raft, it forms like a covering, and it stays there for some hours. Okay, it forms like a covering, like a raft in your lower esophageal part to prevent the backflow of your gastric content into your esophagus. So if your target is to reduce gastroesophageal reflux disease, then you must use antacid that contain alginic acid. That is what I'm saying, because alginic acid works more by forming a raft in your lower esophageal sphincter and prevent backflow of drug of your gastric content, not drug. So that's how best I can explain it. All right. I think that reaction happens when alginic acid comes in contact with your hydrochloric acid. For your gastroesophageal reflux disease, if you want to recommend an antacid for your patient, okay, tell that patient to, no, not tell, ensure that you recommend the one that contains alginic acid or alginate, anything alginate. Recommend it for that to that person, because that is what is going to prevent that gastroesophageal reflux disease. So when you pick up some bottles of antacid, you will see alginic acid. So you will know that, oh, this antacid will be more effective in preventing gastroesophageal reflux disease, or it will help with gastroesophageal reflux disease. But if your patient complains about reflux and your antacid does not have alginic acid, it will still work, okay? Because you know antacid will neutralize the acid in the stomach, but it will not form that raft to prevent reflux disease. All right. So that's why people who have reflux take Gaviscon, because Gaviscon is by far, I think, the only product I know that has very high strength alginic acid that can protect and form that raft, but it's expensive. That dude is expensive. So That's it. Antacids can help you for peptic ulcer disease and all of that, and all that. But they are not commonly used. The reason why antacids are not commonly used because we now have proton pump inhibitors, and they are the most potent suppressor of hyperacidity. So that's why antacids are not common. Antacids are used PRN. What is PRN? What is PRN?
When needed.
When needed, when necessary, blah, 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 between meals and at bedtime. Okay. The reason why antacid, particularly for patients who have some of these conditions, is important they take antacid at bedtime because and acid production continues into the night. It's easy for the acid to reflux into your esophagus. Okay, so reflux is common at night. In fact, one of the lifestyle modifications for someone who has GERD is that don't eat late at night, because when you eat late at night and you go to bed, in fact, the advice is that eat 3 hours before you go to bed if you have GERD. And the reason for that is because when you eat late in the night, who can give me the reason for that, the rationale for that? We have said so many things. So why would you advise a patient with a GERD to eat 3 to 4 hours before going to bed? Okay, yeah, go ahead. This is the first time you would say something in this class. Oh yeah, go ahead. In this semester.
Okay, so sir, most of it, like if the patient did not eat 3 hours before going to bed, the food stays in the stomach, and the activity of the acid causes it to like there'll be an acid reflux back to the esophagus. Due to the fact that the stomach acid and the food is still interacting, and the person is not lying down again. So the acid goes straight to the active acid goes straight to the esophagus, causing GERD to come up again.
You are a genius. Thank you very much for that. So that's it. All right. Now we call it a day here because your threshold has been reached. We cannot go further. Any question? We'll be meeting every Monday like this because I'm also going to take you CNS pharmacology, bipolar disorder.